everyone who is joining us for webinar number 174 since the Andean Health Organization Hipólito Unánime Agreement started a webinar series in May 2020. COVID-19 pandemic teaches us that it is necessary to act reflexively and carry out real transformations in the way we see life and act in the world. It is urgent to change the way we produce, consume, and relate to each other. We are facing a zoonotic disease resulting from human mistreatment of ecosystems. It is essential to take care of our Mother Earth as the risk of getting sick increases with the planetary crisis. Unjust inequalities, climate change, loss of biodiversity, pollution, and waste. The COVID-19 pandemic also teaches us that the capacities built and strengthened in these 3 years must not be rolled back, and health must remain at the heart of policies. Research, epidemiological and genomic surveillance, vaccine and drug development, and the deployment of health promotion and prevention measures are essential for a new caring society. Reflections on these and other priorities relevant to health and well-being can be found in the monthly Notice Salud Andinas newsletter, available on the Andean Health Organization's website. We invite you to leave your name, organization, and country in the comment box of the Facebook Live or YouTube Live chat. In the same space, you can leave your questions or send them via email to webinarhorasconu@gmail.com. In this webinar, we will follow the usual dynamics. We will start with the institutional greeting, followed by the presentations of our speakers, and then we will move to the Q&A session. To access the certificate of attendance, as usual, in any of the chats of Facebook Live or YouTube Live, you will find a fixed link where you must fill out a brief survey and leave your data as email. Please verify that your email is correctly written for sending the certificate, which will be sent in the coming days to your emails. To begin this important day, I give the floor to Dr. Maria del Carmen Calle Dávila, Executive Secretary of the Andean Health Organization, who will give the welcome and institutional greeting. Go ahead, Dr. Calle. Thank you, Lucho. Well, arterial hypertension is considered a disease of multifactorial origin and defined as the increase in blood pressure figures above normal standards, or blood pressure equal to or greater than 140/90. Affects more than 1 of 4 men and 1 in 5 women. In 2019, the overall prevalence of hypertension, standardized by age in adults aged 30 to 79 years, was 32% in women and 34% in men, and has continued to rise due to overweight and obesity, inadequate eating habits, decreased physical activity, and behavioral aspects interrelated with toxic habits, such as excessive consumption of alcohol and tobacco, stress, inadequate lifestyles, neglect of cardiovascular, cerebral, and renal diseases, which often occur in the most productive stage of life. resulting in a significant reduction in life expectancy and accelerated mortality. Cardiovascular diseases kill million people every year. And of these, 9.4 million deaths are directly linked to hypertension problems. One of the largest studies conducted to determine the prevalence of hypertension and progress in treatment over the period 1990 to 2019 studied more than 100 million people aged 30 to 79 years from 184 countries. That the burden of the disease has shifted from wealthy nations to low and middle income countries. In 2019, more than 1 billion people with hypertension, 82% of all people with hypertension worldwide, lived in low and middle income countries, and that 46% of hypertensive adults are unaware they have this condition. And those who are diagnosed, only 42% receive treatment. One of the global targets for non-communicable diseases is to reduce the prevalence of hypertension by 25% by 2030 from the 2020 baseline values. And this requires improved detection through blood pressure measurement, either at home or in a health facility, and can often be effectively treated with low-cost medications. Concomitantly, it is important to implement measures such as healthy, low-salt diet, reducing body weight, activity, smoke cessation, and reducing alcohol intake. In addition, it is important to increase and improve medication, diagnosis, and care of comorbidities, such as diabetes and pre-existing heart disease. To learn in detail the characteristics of hypertension and the magnitude of this disease, we have invited Dr. Ramon Martinez, specialist in health metrics of the Pan American Health Organization, who will talk about the topic of the mortality and the impact of hypertension and control in cardiovascular mortality. Our second guest is Dr. Jose Drago, President of the Peruvian Society of Cardiology, and he will talk about the impact of hypertension in the Peruvian population, diagnosis and treatment, and finally, to address strategies for the prevention of hypertension and other cardiovascular diseases. We have invited Dr. Lendert Nederveen, Regional Advisor for the Prevention of Hypertension and Other Cardiovascular Diseases, to address the issue of less salt, more health, and he will talk about the technical guidelines to reduce salt consumption. Thank you very much for the participation of such distinguished speakers in this webinar number 174. The Andean Health Organization Equality Non-Agreement carries out since May 8, 2020. Thank you so much. Welcome. Thank you very much, dear Dr. Calle, Executive Secretary of the Andean Health Organization, Hipólito Unanue Agreement. we invite Dr. Patricia Gallardo, international consultant of the Sub-Regional Program for America from WHO, PAHO, on behalf of Dr. Hernán Sepúlveda, head of PAHO, for the institutional greeting. Go ahead, Dr. Patricia. Thank you, Mari Carmen and Lucho. For us at the Sub-Regional Program for South America, the effort from PAHO at different levels with the interface of the central unit in Washington, D.C. These cases are very important to exchange knowledge of the lessons learned that are going to generate it in this subject so important of the first causes of mortality and disability for non-communicable diseases. Just add to what Dr. Calle mentioned is that in that the effort has to be between programs. We need to work as a team, a life course with gender perspective, and knowing that this goes beyond health. It has a great economic impact, and something important for us are the social determinants in vulnerable populations in our Andean region. Just to thank for this space of this exchange and be able to share knowledge, and to thank my colleagues from PAHO for their time, for their valuable time, and to the other speakers. Thank you very much for the invitation. Thank you, Dr. Patricia Gallardo. After the greeting from the institutions, I introduce myself. My name is Luis Bengolea Moore, medical epidemiologist, coordinator of the Andean Committee of Non-Communicable Diseases, the Andean Health Organization, and today with great pleasure, I will be in charge of moderating this webinar. We invite Dr. Ramon Martinez for this presentation. Dr. Martinez is a systems engineer, specialist in population health metrics, Department of Non-Communicable Diseases and Mental Health of the Pan American Health Organization, World Health Organization. Dr. Martinez focuses on studies aimed to the quantification, monitoring, and analysis of the burden of non-communicable diseases, injuries, and the risk factors in the region of the Americas, and leads the PAHO Enlace data portal dedicated to non-communicable diseases, mental health, and injuries. Ramon Martinez is also a member of the regional technical team of the Heart Initiatives in the Americas. Go ahead, Dr. Martinez, you have the floor.
Está silenciado, doctor Martínez.
Thank you very much for the introduction. It's a pleasure to be with you and to share the information from this region in terms of mortality due to cardiovascular diseases and hypertension. The content of my presentation, I want to be talking about the levels and trends for cardiovascular disease mortality, ischemic heart disease, and stroke. I also talk about the levels and trends of the hypertension measurements and the treatment cascade. I will briefly talk about a study that we quantify the association between the population hypertension control and ischemic heart disease and stroke mortality. Finally, I will make a brief demonstration of a tool that we have developed that uses the results of the association of content number 3 in order to first estimate how much could we save in terms of death due to ischemic heart disease and stroke if we can increase the control of population of the hypertension at the population level. As you know, and it has been mentioned by Dr. Paye. Cardiovascular diseases are the leading causes of mortality. Ischemic heart disease, this is in the Americas. Ischemic heart disease and stroke have number 1 and 2 of causes for mortality. When we look at the Andean region, we see the same pattern. Ischemic heart diseases and stroke are the leading causes of mortality in the sub-region, and these causes are maintained in those positions since 1990. This is year 2019, but since 1990, these are the leading causes of mortality. Here I show you, look at the regional level, since 1990 to 2019, the trends of mortality due to ischemic heart disease and stroke. In blue, ischemic heart disease with the highest levels, and in red, we have stroke. You can see in both sexes there's been an important reduction. However, in recent years, there is sort of staggering of the trends that we have reported in previous studies. When we look at the situation in the Andean region countries, we can see a significant reduction. Almost all countries have been able to reduce mortality rate by both causes. However, there is a more visible plateau in countries such as Ecuador, where the trend is plateaued in the last 2 decades. We see the case of Chile, interesting, where they've been able to reduce mortality levels due to ischemic heart disease, similar to cardiovascular disease. However, there's a large variation in each country. In the Americas, just want to highlight, I'm showing mortality by both causes alone. And please note that mortality due to ischemic heart dominant in all countries when we put it together, ischemic heart disease and stroke. On the other hand, upper graph, we've showed the top 5 countries with the worst situation both for men and women. And the lower portion, we see the countries that have the lowest rates or more favorable rates, and you see countries like Peru in the Andean region had the lowest mortality rate by both causes. However, in this graph, we see a large variability in terms of the mortality levels by this condition. For example, we have Guyana, men 3 times more higher mortality compared to Peru. There's a large variability, and we need to analyze each country situation on a more specific way. Here I show a similar graph for countries of the Andean region. Include the Americas, so you're going to see that in men, Venezuela and Bolivia have the highest levels in the region. Venezuela and Bolivia also have the highest rates in the sub-region. And once again, the case of Peru and Chile, the countries that have the most favorable age standardized death rate. I wanted to show you now what we are finding in terms of the prevalence of hypertension. The black line represents the region of the Americas, and the rest of the lines are countries from the Andean region. You can see that there are 2 countries have highest levels of the Americas, which this is Venezuela and Chile. The trend in Chile, we see that in recent years, the last decade and a half, there's been a significant reduction of the prevalence. However, they still have levels above the regional prevalence. The rest of the Andean region countries are below the regional level. However, we can see some countries that they have increased their trends, mostly in men, that we need to pay attention to. Now, there's a more interesting element that we're analyzing, and this is the indicators of the treatment cascade. These report on the performance of health services to treat, prevent, and control hypertension. And we are showing in the graph of the left the trends of 1990 to 2019 for indicators of this treatment cascade. You can see the red area, that proportion of persons that are unaware that they have that condition. And in 2019, that number reached 30% of all hypertension. There's also a fraction that has been diagnosed, are aware of their conditions, that are not being treated. There's another, and that's that represents 10% of all hypertension. We have another band with a light green color, which are those who have been diagnosed, who are treated, but are not under control. And that represents 24% of all the hypertension. And for the case of those who are diagnosed, treated, and controlled, in the region is 36%, and that number has grown significantly at a rate of 3.18% since 1990. Each indicator reports on different diagnose access to treatment, and the effectiveness of diagnosis. And we should review systematically this at the primary healthcare level. There is a large variation among the countries in the region in terms of these indicators. There are countries with favorable situations such as Canada, which in the right side, and countries as with a very limited situations such as Haiti and Paraguay with very low levels of control. So there's a gap in terms of hypertension control, very large. Now, if we look at the countries in the Andean region, we can see the variation that we have in these countries. I have placed the region, the Americas, on the top to use as comparison. And you see that in most of the countries have rates of an awareness of hypertension and have control rates that are below the level. So I want to highlight the case of Peru, has control rates of 21.7%, which are really low compared to the rest of the country. Here we see the trends of the indicators in the Andean region countries. So you see the trends of these indicators. There has been a significant progress between men and women, but there's still much to do in order to improve the indicators of the treatment. Now I'm going to talk about a study that we published last year. We tried to quantify the association that we see between hypertension control at a population level and mortality due to ischemic heart disease and stroke. For that, we use two data sources. We use mortality estimates from the burden of disease study. We also used the estimates of hypertension control at a population level from the study of the group of SED for collaboration, and we have 30-year data from 36 countries and territories of the region with a large volume. And with this data, we, as you can see in the graph, the continuous line represents the models that were best adjusted of this regression analysis of these two measurements, and that dots represent each country of the Americas region with the data available, and those data points correspond of the estimations of the year 2019. There's a large variability in between among countries, those with a mortality due to ischemic heart disease and stroke above the expected control, but we would also like to highlight that we found some models that with a better fit, and these models led us to conclude that if we can increase the population control of hypertension in 1 unit, in 1%, we can achieve a reduction of mortality due to ischemic heart disease of 2.9%. And for the case of stroke, it would be 2.4% reduction. These models have been used in order to facilitate their use operative, and we have developed an interactive tool that is available web, and I'm going to show it to you quickly, where is directed to do advocacy with our decision makers so they can identify how much we can save in terms of death of ischemic heart disease and stroke. We can increase our levels of population hypertension control. So I'll quickly show you this tool.
Okay. Pero se logra ver, ¿no?
You can see. So we have two panels. On the left, we have a number of parameters. Action. It shows us situation for the region of the Americas, where we are proposing a reduction or an increase, corrections of treatment of 35, from 36% to 50% in a period of 5 years. And here you can see, according to the model that we are using, we can prevent 419,000 deaths in a 4-year period. Just for demonstration, I'm going to select a country such as Colombia, for example. This is, here I can select the data from the population and the treatment cascade data. In Colombia, you can see that 33% of control, and if we aim to take that 33% to 50%, to scale it up to 50%, in this case, we can prevent more than 27,000 deaths between ischemic heart disease and stroke in a period of 5 years. So we can play with the level of the diagnosis from baseline as well as target for the diagnosis, treatment, and control. Modify these parameters. The ones on the left are real values for Colombia in 2019. And hypothetically, I'm trying to take the baseline from the baseline of 68% of diagnosis to 80%. The treatment from 80.5% to 90%. And in the case of control among those treated from 59.7% to 70%. That takes population control to 50%, and this tool will automatically calculate the death that can be prevented due to ischemic heart disease and stroke. In the lower graph, we can see it in the death we are preventing year after year. And this graph shows the change that we are proposing of hypertension control from 33 to 50%, and how much we prevent in terms of mortality due to ischemic heart disease. And this is the case of reducing mortality due to stroke. From one level to control to another increased level. So I have finished my presentation. I thank you so much for attention, and if there are any questions, I'm ready to answer them. I have an additional slide with resources that can be shared with the audience in this related topic. Thank you so much. Excellent presentation, Dr. Martinez. And for us, it's very important. The information that you have presented, we invite you to stay in our room for the Q&A. There is something that topic that we consider of high value in the information that you have provided to us, and is related to the impact of the health measures with regards to hypertension and the decrease in both stroke and following 1% of reduction or of the prevalence result in a decrease of 2.4% in mortality due to stroke. And in the case of ischemic heart disease, we can achieve a 2.9% reduction in mortality caused by this condition. It's also very important what you've mentioned with regards to how the hypertension behaves in the region of the Americas, being Guyana, the country with the largest impact of ischemic heart disease and stroke. However, below the average in the Americas, we have two Andean countries. One is Chile and the other one is Peru. But you also indicated us that the follow-up of hypertension in our Andean countries is different, and there's a lot of information that we need to improve with regards to diagnosis, awareness, and treatment. Finally, you also indicated that there is a tool that allows us to find out the impact of health measurements for hypertension control and how much we prevent in terms of mortality. Thank you very much. Dr. Ramon Martinez, we invite you to continue in the room. And we will, now we are followed. We would like to invite Dr. Jose Drago. Dr. Drago is an associated cardiologist of the Ricardo Palma Hospital, the president of the Peruvian Society of Cardiology, fellow of the American College of Cardiology, and fellow of the European Society of Cardiology. Dear Dr. Drago, you have the floor. Thank you, Dr. Bengolea. Thanks to the Andean Health Organization, Hipólito, in an agreement, has invited us to talk about hypertension in Peru. What are the figures that we have for diagnosis and treatment? In this opportunity, we're going to mention some of the data that has been obtained in population studies carried out in Peru by the Peruvian Society of Cardiology and by the National Health Survey. And therefore, I don't have any conflict of any disclosure for this presentation. I would like to start with these slides, and 10 years old. They had indicated that hypertension has been mentioned in the previous presentation, was starting to be more prevalent in Latin America than in the countries in North American developed countries. In particular, Peru, the prevalence reached 20% in women and 25% in men. So 1 out of 4 men in Peru may have hypertension. A number of studies has been done. We'll start with the most simple ones. This is a report from the outpatient in our institution. 10 years ago, hypertension was the leading cause of consultation for adult male between 20 and 59 years, and in women, it was at the second place. If we look in those over the age of 60, hypertension is by far the leading cause of visits of the patients who come to the outpatient service. So it gives us the idea of the frequency and what is the age group where we see more frequent hypertension. The Peruvian Society of Cardiology years ago carried out population studies with surveys and measurements of blood pressure. The first one, the Tornasol 1 study, showed that since the age of 18, we found 12% of prevalence of hypertension in men and up to 6% in women. This prevalence was determined by the active measurement of the blood pressure and the survey, population survey. This was studied done in close to 14,000 people nationwide. And we can see that the prevalence clearly increases with age, and it comes to a point in which women are starting at the age of 50, when they go into menopause, they have the same levels of men and get even higher. And we're going to see that women visit more frequently the ambulatory services compared to men, and they receive a better care and better survival. We could also like to indicate this finding of what has been reported in the literature, where hypertension has a different behavior according to age. Up to the age of 50, there's an elevation of the systolic as well as the diastolic pressure. But when you start to look at the elderly, there's an elevation of the systolic, and diastolic pressure remains the same with no variation. This is due to the vascular changes that occur with age, vascular stiffness, hemodynamic changes that lead to an increase in systolic pressure, and therefore this is the main target of the therapy that we must have in our elderly patients. We also have to highlight that hypertension doesn't come alone. In hypertensive patients in Peru, almost the triple risk of having hypercholesterolemia, more than twice the risk of having diabetes, as the same for obesity, compared to one that doesn't have hypertension. It was mentioned in introduction with regards to poor lifestyles that are usually accompany the urbanization of every society. We also have to indicate that obesity is a serious problem in our country. We are finding an association of hypertension, hypercholesterolemia, and diabetes. So the subject who develops obesity have the most important cardiovascular risk factors that are going to have an impact of suffering potentially lethal effects. This is the two studies, Tornasol 1 and Tornasol 2. We were going to carry out the third Tornasol study in 2020, but due to the pandemic, by other political reasons that I'm not going to mention now, we were not able to carry out the third part. But we have to see that according to the current classification at that time, there was a large number of patients with pre-hypertension. Now they will be considered hypertensive according to new criteria. And they don't accept this classification anymore, where the pre-hypertension or stage 1 is between 130/80 and 140/90. Most institutions now, hypertension starts from 140/90. But here we would like to highlight the number of pre-hypertensives is growing. So we expect that if we will have more recent data, we will have greater data for hypertension. And this is what we're going to present with other surveys carried out. And another of the important data that we have here, provided by these studies, is what Dr. Martinez mentioned, the rate of awareness of hypertension and the rate of control of hypertension. In 2006, we had a very low awareness rate. Close to 45% of people knew they had hypertension, but most of them didn't know. From them, very few were aware of treatment, and only 15% had a blood pressure. And in 2011, this rose to 20% control, and we hope that this continues growing year after year. But there's a certain number of obstacles that prevent this, and we're going to discuss them later. What is the impact of the lack of control or awareness of hypertension? Well, in 2017, among the most leading causes of mortality reported from the Ministry of Health of Peru, we found ischemic heart disease and stroke, as well as other like renal failure is an important cause of morbid mortality that goes together with hypertension. Hypertension and diabetes are the most leading causes of renal failure worldwide and also in our country. 2 years ago, in 2021, the Ministry of Health reported that there had been an estimation of almost 23,000 deaths due to ischemic heart disease, with very few differences between men and women, but it was mostly in the elderly. So this is reflecting precisely what we had been reported in previous years, that there were some difficulties in being aware of the disease and treatment. And we know from other registries, such as the myocardial infarction registry, hypertension in patients who come with an MI to the ER is the leading cause reported by those patients. Almost 70% of all patients who came to the ER with an MI have hypertension, and in second place, overweight and obesity. A third of the patients have overweight or obesity, other risk factors, dyslipidemia, and diabetes. The National Health Survey carried out by our statistics institution reported that for 2021, the prevalence, but we have to indicate that the population has been extended from 15 years of age in comparison with the population that was evaluated by the Peruvian Society of Cardiology. that starts at the age of 18. This small segment of 3 years segment is very little affected by hypertension because as we've seen that the prevalence increases with age, reaching the highest prevalence at the age of 50 or 60, with difference between. So having this 22.1% in over the age of 15, we're talking about for those over the age of 18, approximately of 26%, where we see that men were more affected than women. And it's interesting to note, look at the prevalence in the different natural regions of Peru. Peru in the coast region is the most urbanized. The highlands and the jungle, more rural areas. Therefore, the difference, although coast is above the national average, the cities in the highlands and in the jungle will be below. And of course, we need to differentiate that perhaps, or probably the most urbanized cities in these regions may have values that can be similar to the coast region or very close to it. As opposed to what we see several years ago, if the patient was mostly rural, they didn't have the high prevalence of hypertension. This map published by this national survey, where the highest percentage, almost 29%, in the coast region, especially in the city of Lima and the region of the port of Callao. We have statistics that they may have up to 30%, similar to what we see in the north coast, as well as Arequipa, Moquegua, and Tacna in the south. There are regions in the most rural areas, in the highlands and in the jungle, like Junín and Ucayali, have lower prevalence of hypertension. So hypertension is associated with urbanization. And here we would like to show what is being reported by this national survey with regards of those who had a diagnosis of hypertension by a physician. This is quite poor. Of 24 to 26% of men that may have hypertension, only 1/3 have visited the doctor and have a diagnosis of hypertension. In women, this percentage is higher. Women tend, because of psychological characteristics, to go to medical care more frequently than men. And only 60% of the population that visited the doctor and was diagnosed of hypertension has reported that has received treatment in the last 12 months. So 40% of people, either men or women, who were diagnosed of hypertension are not receiving treatment. And this low compliance is higher in the highlands, perhaps because difficulties in making people aware that they need to take their medication. That makes it difficult to comply with treatment because it's a silent disease. To provide medication where you don't feel any improvement, it's not that it gets the pain away, or so they don't find a reason to take the medication. As Dr. Martinez has shown, what the impact that we can have in reducing mortality when we do an adequate control of hypertension. We also made a review during the pandemic. Those facilities were closed, no primary care, and we tried to do a small evaluation in 50 patients that we follow them for their blood pressure control, and we found something interesting. If you do adequate follow-up, we can have high rates of control, systolic pressure close to 70%, diastolic almost 100. That is the classification that I mentioned. But what we need to highlight here, that only 15% of the patients were receiving monotherapy. So 85% were receiving combination therapy. So a concept that we need to have There is a hypertension not only needs to be detected and diagnosed and studied, we should provide the adequate medication. Adequate medication for hypertension in most of the international guidelines is provide combination treatment. And for that, I would like to show what the WHO published last year, where they show the therapy groups, and they suggest that combination therapy in a single tablet, which increases adherence resistance in order to achieve goals that most people are below 140/90, and the goal for patients with comorbidity may be with a systolic below 130. So we not only have to treat blood pressure, but treat it adequately. For most of our patients, we need to use combination therapy and have treatments in one single tablet so patient can have a good compliance. The messages are to call for action. We have 25% of Peruvian adults with hypertension. Wherever we go, we're going to find a hypertensive patient. Every doctor who sees patients has to diagnose, has to measure blood pressure, something as simple as that. We need to be careful with age. We can reach prevalence of up to 50% when we talk about the elderly. So we need to be much more careful with this evaluation. We need to measure pressure because it's very likely that you're going to have high blood pressure, no matter what the reason why they came for to visit the office. And the timely diagnosis and adequate measurement, and to make the patient aware, we will decrease the gaps between diagnosis and treatment. Of course, improving the medication dispensation and having in the health institutions with combination medications, and also actions for the early diagnosis and detection, and give the adequate treatment, make patients aware that they need treatment because that's shown to be effective in preventing cardiovascular events. Thank you very much for your attention. Excellent presentation, dear Dr. Drago. There's a wealth of information. I would like to underline with regards to the experience through several studies carried out by the society. And one of the important topics, relationship between hypertension and men and women prevalence. And according to the studies, more in men than in women. That's an important conclusion of those studies. However, the growth of increase in diastolic and systolic hypertension, when they reach before the age of 50, they go hand in hand in terms of the sustained increase. However, from that period, the systolic pressure increases more than, and the systolic remains similar, and you explain the reasons behind this difference. Another important element that we need to take into consideration is related to the possibility that in our country, the awareness of the disease is low. It's around 45%. What's more serious is that treatment is way below that figure. And that is also important to consider in order to write to conclusions about this issue. The patients who come with ischemic heart disease, most of them have hypertension. There's a strong association between MI and hypertension. And something else that you mentioned that is also important, the effect of overweight and obesity in this complication.
ONU ha tenido la posibilidad de trabajar
ONU has been able to
para la preparación conjuntamente con los
do
países
work
de
with the
una
countries
resolución que
on a resolution that
la obesidad
identifies
como una enfermedad.
obesity,
Y esto implicará toda una
and
serie
this
de
it will
acciones
imply a
para
number of
lograr la
actions
disminución
in
del
order to
sobrepeso y la
decrease
obesidad.
overweight and obesity.
Finalmente, creo que hay
Finally, I think
que dejar evidente
that
que hay
it's
algunas
evident
recomendaciones
that
concretas
there are
dentro
key
de la
recommendations
propuesta que usted nos ha
in
hecho en
the
su
proposal that
exposición.
you have presented to
Y
us.
creo que una de las más
And I
fuertes
think
es
that
el
one of the
trabajo y el
strongest one is
esfuerzo
the effort that
para
has to be done
evidenciar, en
to
primer lugar, que hay una muy baja, un
indic
bajo
indicate that
esfuerzo
there is a
y
very
también preocupación por parte de nuestra
low
población
concern
para
on our
conocer
population to
la
learn about
hipertensión
their
no
disease.
está debidamente conocida
Hypertension
y
is
más
not
aún
adequately
porque los
known,
medicamentos que pueden
and the
utilizarse
medications that can be used
son de bajo costo y pueden
are
ser
of
atendidos
low
en la
cost
atención
and can
primaria.
be described at the
En Perú,
primary
la
health care
hipertensión
level.
está alrededor de un
In Peru,
25%
hypertension
en
is
los adultos y esto
prevalence
también
of
es una de las
25% in adults,
recomendaciones que nos hace para
and
seguir
this is one of the recommendations
el
that you tell us
seguimiento
to
de la
insist
hiperpresión
in
arterial.
follow-up of hypertension.
Doctor Drago, muchísimas
Dr.
gracias
Tao,
por
thank
su
you very much
presentación.
for your
Le
excellent
invitamos a
dissertation.
permanecer en sala
We
para que nos
invite
pueda
you
brindar
to remain in the room
también las respuestas a
so
las
we can
consultas que
go
hemos
into
estado
the
llegando.
Q&A session.
Muy amable.
Very kind.
Seguidamente
Now,
invitamos a
we would like to
Leo
welcome
Nederveen.
Dr. Leo
Él
Netherbean.
es jefe de
He
la
is
unidad de
chief
factores de
of the
riesgo en
Risk
nutrición,
Factors and Nutrition Unit,
asesor en alimentación,
advisor on food,
fisiología y
nutrition, and
actividad
physical
física
activity
en escuelas
in
y
schools of
departamentos
the Department of
específicos y
Non-Communicable
voluntarios
Diseases and Mental
de la
Health
Organización
of the Pan
Mundial de
American
la Salud.
Health Organization.
Adelante,
Go
doctor
ahead,
Leo
Dr.
Nederveen, le
Leo
cedo el
Netherbean.
espacio.
You have the floor.
Muchas gracias por la invitación.
Thank you very
Voy a
much for the invitation.
compartir pantalla.
Going to share my screen.
Espero que ya puedan ver la presentación.
Correcto, si lo vemos.
Muy bien. Bueno, esta semana también es
This
semana
week,
de sensibilización
we
de
are creating
sal.
awareness on
Entonces, no
salt.
solo tenemos esta semana
We not only
el
have
Día
this
Mundial de
week, the
Hipertensión,
World
sino también
Hypertension Day.
toda la
We
semana
also,
estamos
this
dedicando
entire week,
atención
we are
sensibilizar sobre
creating
los
awareness
peligros de
on
salud
the
del
danger
consumo
of
de sal. Y me
salt
voy a
consumption
enfocar en
in terms
esta
of health. And
presentación
in this
en las
presentation,
herramientas que
I'm going to
tenemos
focus on
para
some tools
implementar
we
programas de
have for
reducción
the
de sal.
implementation of programs of reducing salt consumption.
Entonces, esta guía se llama Shake, que ya les voy
Guideline
a
is called
ir
Shake,
presentando.
and I'm going to
Bueno,
introduce them to you
como ya
later.
estuvimos viendo,
As we've heard,
uno de las primeras causas
one of the
de la
first
presión
causes
arterial alta es el
of
excesivo
elevated
consumo
blood pressure is
de
the
sal. Y esta
excessive
presión
consumption of salt.
arterial alta
And this elevated
contribuye
blood
o
pressure
lleva a
contributes
10.8
to
millones de muertos.
10.8 million of
Eso fue en
deaths
el año 2019.
in the year 2019.
Vemos que la OMS
We see that
recomienda un máximo
WHO
de 5
recommends
gramos
a
de
maximum
sal
of
como
5 grams of salt
cucharadita al día,
teaspoon
pero el
per day,
consumo actual
but the
está
current
casi dos,
consumption
tres
is
veces
almost 2 or 3
mayor
times
y
greater,
por eso pues
and therefore
hay mucha presión arterial
there
y
is
otras cosas
there's a
y también
high levels of
enfermedades
hypertension and
cardiovasculares.
other cardiovascular diseases.
Entonces, la OMS a
So
través de las
WHO,
directrices que han
through the
emitido,
guideline that has been
recomienda el
issued,
consumo de
recommends
sodio hasta un
lowering sodium
10% al
intake
tensión
in order to
arterial,
reduce blood
eso
pressure and the risk of cardiovascular
cardiovasculares
disease
y los accidentes
and
cardiovasculares
stroke,
y cardiopatías
coronary
coronarias
heart
entre los
disease
adultos,
among
que es una
adults. And
recomendación
is a
fuerte o firme.
strong recommendation.
También
They
hay un
also
límite de 2 gramos
recommend reducing the
2
intake to
gramos de
below
sodio,
2
que
grams
equivale a 5
that
gramos de sal
are
al
equivalent to 5 grams of salt for adults. But because children and their energy requirements are lower, this value has to be adjusted of 2 grams per day. There is a almost linear correlation between sodium and blood pressure. The lower the sodium, the lower the high levels of hypertension. And the benefits are greater when you reduce low 2 grams. We have also seen in our countries that consumption of the processed and ultra processed product has increased. And these products usually high in fat, sugar, and salt. So they contribute that more and more the salt that we consume comes from processed and ultra processed products. And we don't see it because it's included in the food, but we consume this product is hidden in those products. WHO has created a shake program with this collaborating Australia, and this shake tool includes the lessons learned from many countries throughout the world, in particular those with mid and low income countries. And this helps for a gradual and progressive reduction in the proportion of salt in food. And if we can achieve these, there will be a lowering of blood pressure and we reduce mortality. And in addition, it has significant on the countries. A population that is healthier, more healthy labor, less health system expenditure, and benefits for economic growth. The shake package is an acronym that comes from the English word S stands for surveillance, H is for harness the industry sector for reformulation of foods. The A stands for to adopt standards for labeling and marketing. A stands for knowledge, to educate and communicate population. And E stands for the environmental intervention for supporting healthy eating or healthy environment. And I will talk a little bit more on each one of the different components.
Vigilancia o surveillance en
For
inglés.
surveillance, it's important to measure and monitor salt use. It is important to carry out specific surveys to measure the content of sodium in the urine that can be part of the steps for risk factors surveys, and also provides a baseline of salt intake. But but not having that baseline is not an argument to move forward with the programs in reducing salt consumption. It's also important to have data on salt use and the main sources. We need to know if most of the salt comes from processed food or from what is added when cooking, or if we can define the strategy. It is also important to monitor the content of sodium in the different food groups and use surveillance
monitorear y
to
evaluar un programa de
monitor and
reducción
evaluate
de
a
saldo.
program for all leaders.
Es importante movilizar
It is
el
important
sector como otro
to
eslabón,
harness
otro
this
componente de Shake.
industry sector as another
Entonces,
component of Shake.
para
So
ello
for
se
that,
puede reformular los
we
alimentos,
reformulate
hay que
foods
fijar metas para la cantidad de
to
sal en los
define
alimentos.
reduction
Otra vez
targets
es importante
for
seleccionar
salt
categorías de alimentos
reduction
donde
and
el factor
to
sal tenga
see different
incidencia
categories of
y
food,
metas de reducción para
establish
esas
the amount of
categorías que pueden
salt,
ser pan,
and to
quesos,
establish
embutidos.
goals for
Hay
reduction,
que ver,
can be bread, cheese,
priorizar los
sausages,
alimentos con
etc.
mayor
We have to
contenido de sal
prioritize those foods that have the highest salt
o
levels
alimentos que
or
no tienen tanta sal,
foods
pero
that don't have too much salt,
por la cantidad
but because of the
en que se consumen esos
amount
alimentos
they are consumed,
contribuyen mucho
they
al
may
consumo
contribute to
de sal total, como es
the
el
total
caso del
salt
pan, que
consumption,
tiene
such as
menos
the case of
panes,
bread
quesos y
that
embutidos,
has
pero se
less than
consume en
cheese
mayor
and
cantidad.
cold meats,
Y
but
se
is
pueden
consumed in
establecer
more
metas
amount. So we can
máximas y
establish
ponderadas de
goals
reducciones
for
porcentuales, puede ser
percentage
voluntario
reductions,
o
weighted
obligatorio
averages
desde el
that can
primer
be voluntary or
programa
mandatory,
e
and we need to
implementación
have
en
a
diferentes
timetable.
países que
We've seen
una ley
in different
obligatoria
countries that
es efectiva
law,
y
mandatory law is more
las
effective,
empresas o
and all
productores están
the
en la misma
industry will
condición
be with the
y eso
same
facilita
condition, and
la
that
implementación. Las
facilitates
metas
the
suelen ser más
implementation, and the goals
ambiciosas,
are more
son
ambitious,
obligatorias y también
and they are
estas
mandatory,
difícilmente
and a law is
se
more
elimina en
difficult
caso de un
to
cambio
be
de gobierno.
deleted in the
El otro componente de Shake
change of the
es la
government
adopción de
administration.
normas.
The other
Muy
letter of
importante
the
en nuestros
acronym is A for
países
adoption,
es la
which is very
adopción
important for our
en varios
countries,
países de los sistemas de etiquetado
is by
frontal
considering
alto
the
en basados
labeling
en el perfil de nutrientes de
based
la
on the
OMS,
nutrient profile from
el alto en
PAHO,
sodio, ácidos grasos trans, grasas saturadas o
saturated
azúcares
fat, sugars, or
permite la fácil
allows
lectura por
the
parte de los
easy reading by the
consumidores y
consumers.
esto se ha visto en
And in
Chile,
fact,
por ejemplo,
Chile, we've seen
ha contribuido
that
también a la
has contributed
reformulación
to the
porque los productores
reformulation
por
because
evitar
the
el sello
manufacturers, in order to
reducido en la
avoid
cantidad de la sal
the
en los alimentos. Hay
octagon,
que
have
combatir
decreased the
también
content of
promoción
salt.
engañosa de
We
alimentos
also
con
need
elevado
to reduce
contenido de sal.
misleading information with
Muchos
salt content.
alimentos
Many food products,
procesados
processed
figuran, por ejemplo,
products
textos que
have text
enriquecidos en hierro,
that are
otras vitaminas y
enriched with iron
micronutrientes que al
and
mismo
vitamins,
son
but at the
no
same
elevados
time
en su contenido de
have
sal,
an elevated content of
solo lo
salt,
mencionan en letras
and is only mentioned in
pequeñas
small print
en la etiqueta nutricional
in the
al
nutritional
dorsal
label in the
del paquete.
back of the pack.
Importante también que esta
Also
población tenga
important that the
más
population
conocimiento,
have more
que
knowledge.
entiende que es importante
They
consumir
understand that it's
menos
important
sal,
to
su
consume
relación
less
con
salt,
la
and
hipertensión y
in
otros
the
riesgos
relationship with
para la
hypertension
salud.
and other risks
Para
for their
eso
health.
estamos promoviendo
And for that, we are promoting
estrategias de comunicación
communication strategies,
social, digamos, y también de mercadeo social.
social
En eso
marketing, for
tenemos
example,
un
and we have
programa en nuestro
a
campus
program in
virtual
our
que es
virtual campus
de acceso en español
that has
y en
access
inglés sin
Spanish and
costo
English
y incluye
free of charge,
5 módulos
and includes 5
dirigidos a
models
personal de salud y les guía a
directed
través
to
de
health
todo el proceso
personnel,
de
and they guide them
preparar
through the
una
process
campaña
of how to
eh,
prepare
de mercadeo social
a social
efectiva,
marketing
porque
campaign
a
that's
veces
effective.
únicamente se piensa
Because
en
sometimes
el
we think
afiche y el
in the
folleto, pero
poster or
no
the
se pasa por todo
brochure,
el
but we
proceso
don't
de
go through the entire
una
process
investigación formativa para
of
ver qué
formative
efectivamente
research
son
to
las
see that
barreras
indeed
y los
what are
factores que
the
pueden
obstacles and factors
facilitar ese
that
cambio
can
de
facilitate that
comportamiento. Entonces,
change in
como
behavior.
todo proceso
So all the strategic process
se explica en
is
este
explained
programa de
in this
mercadeo social.
social marketing
Otro
program.
elemento es
Another
de
element
los entornos.
that of the
Hay que
environment,
apoyar a los entornos también
support
para
an
que
environment
establezcan
so they
normas
can
y estándares
establish
para reducir
healthy
la disponibilidad
standards
de los
to
alimentos con
reduce
contenido
the
de sal en las
availability
escuelas.
of
Muchos
salt-containing
deportes
foods
y otros
schools
espacios a través
or
de
workplaces,
niveles máximos que pueden
establishing
hacerlo.
maximum levels
También
that can
figuran
be.
los restaurantes.
It also
En algunos países
considers restaurants.
han establecido
Some countries have
regulaciones para
established
quitar
regulations
los
to
salgueros de las mesas en
remove the
los
salt shakers
restaurantes.
and the restaurant
Entonces,
tables.
todas las instituciones
So all
especialmente
the
las públicas,
the public
pueden
institutions
establecer normas
can establish
para tener una
standards
alimentación más
to
saludable.
have a more healthy nutrition.
Nosotros hemos hecho también un
We
mapa
have also
de la
do a
implementación de
mapping
los diferentes
of the
componentes del paquete
implementation of the
ya
different
sea
components of the
nutrition
shake
advice
package
o sea intervenciones
interventions
efectivas según
that
los
are cost
criterios de la
effective according to
OMS.
the
Este mapa
WHO
está
criteria.
publicado en
This
inglés y en
mapping is
español
published in English and
y
Spanish,
también está
and it's
disponible en
also
forma
available
interactiva
with an
en la página
interactive
web que
tool
se llama
in our webpage
Enlace, que es
called
precisamente el
Link
doctor
that
Martínez aquí
Dr.
presente, es
Martinez,
el que ha
who is here present,
preparado todo
has
esta
prepared
plataforma enlace, digamos, donde no
this
solo se
Enlace
encuentra
platform
información sobre
where we not only
los sal,
find
sino
information about
otros
salt
factores.
consumption, but many
Eso
other risk factors
y las propias prevalencias de las
and the
diferentes
prevalence of the
DNTs.
different DNTs
Em,
or non-communicable disease.
Además, les quiero mencionar
In
que
addition, I would like
hace
to
un
mention
año y medio
that
la
about a year and a
organización
half ago, the Pan American Health Organization
lanzado unas metas
launched
actualizadas de reducción
some
de sal y les voy a
updated
comentar
targets for
un poquito más.
salt
Hay un
reduction,
documento que
and there is this
las
document
metas
that
en sí
has the
y hay
updated regional sodium
una
reduction
publicación
target.
también que es una
And we also
herramienta
have another
utilizada
tool
de abogacía también
with
que
advocacy
explica
messages that
cómo lograr
explains how
la implementación de
to
estas
achieve the implementation,
metas revisadas.
these
Acá
reviewed
pueden ver
or updated goals.
12 ejemplos de las
You have the
categorías,
examples of the categories,
16 categorías
the
y hay
16 categories
75
and 75
subcategorías
subcategories.
y para cada
And for
categoría hay
each
una
category,
meta
there is
para
a
el
goal for
2022 y otra meta
2022
para
and
el
another goal for
2025. Y
2025.
como ya dije en
And
un
as I
principio,
mentioned,
estamos apoyando a los
we are
países
supporting
para
countries
lograr la adopción
to
obligatoria
for the mandatory
de
adoption
estas metas
of these goals,
y son factibles,
and they are
las metas
feasible.
en función de estudios de
These
sal,
goals were established
del
following
contenido de
studies
sodio en
of the
productos
sodium
en
content
diferentes
in products
países y
in different
por
countries.
eso la meta más
And
estricta
the
del
most
25 en este
the
momento ya el
2025 goal,
25% de los países
we have
la
25% of the
cumplen.
countries
Entonces,
are
en realidad
complying with it.
pensamos
So we do think
que estas metas
that
son
these goals
factibles.
are
Por eso es
feasible.
importante que los
Therefore, it is
países
important that the
asuman
countries
liderazgo
take the lead
para poner en marcha esta
and
iniciativa,
launch this
adoptar las
national
metas
initiative to adopt
y promover
goals
también
and to promote
la implementación y aplicación de otras
implementation and application of
políticas,
other policies,
porque el shake es más
because
efectivo si
shake is more
todas las
effective
acciones se
if all
implementan
the actions are
conjuntamente.
implemented
Y
together,
es muy
jointly.
importante
And
promover
it's also very important to promote
multisectorial,
the
evitando
multi-sectorial action,
posibles conflictos de
avoiding
interés.
possible conflicts of interest.
Muchas gracias por su
Thank you
atención.
very much for your
Es,
attention. And
Semana Mundial de
this is
Sensibilización
the
de Sal. Les quiero informar que
World Week
mañana
for
a las
Salt
11 horas de
Awareness.
Washington tenemos
Tomorrow at
una
11 a.m.
un
Washington
webinar
time,
sobre
we're
la
going to have
reducción
a
de
webinar
sal
with
y
regards to
voy a
salt
enfocar
reduction.
la
and you can find the invitation in our
nos ha
web
escrito
page
todavía. Muchas gracias.
where you can register. Thank you very much.
Muy amable, doctor Leo.
Very kind Dr. Leo Netherbean.
Gracias por su excelente
Thank you for your
presentación.
excellent dissertation.
Concluimos, a
We,
través de nuestros
through
expositores,
our speakers,
presentado una
we have
relevante
presented
información de la situación de
important
hipertensión,
information of the situation of
complicaciones en las
hypertension and
Américas.
their complications in the Americas.
Finalmente, el doctor
And now,
José Drago nos hizo una
Dr.
presentación
Jose Drago
muy
made a
clara de las
very clear
diferentes
presentation about the
acciones que se
different
han llevado a cabo a
research
través de la
carried out
Sociedad Peruana
through
de
the Peruvian
Cardiología
Society of
y
Cardiology
por otras
and
instituciones
by other
del país
institutions
que hacen
in the
evidente
country
problemas
that
con
have
la hipertensión y
evidenced
su
the problem
conocimiento.
of hypertension and their awareness.
Leo
And Dr.
señala
Leo
que
Netherbean,
la alternativa, una de
who
las
is
alternativas
doing one of
más
the most
costo-efectivas para el
cost-effective
control de la
interventions
hipertensión.
for controlling
Indudablemente
hypertension.
que la propuesta implica una
This
serie
proposal
de
implies a
compromisos
number of
políticos y técnicos
political and
en
technical
nuestros
commitments
ministerios.
in our
Un
ministry.
punto clave dentro
A
de esta
key
evidencia nos la dijo al inicio de su
information was
disertación,
given at the
en
beginning of his
que
presentation,
se
where
recomienda
they
diariamente
recommend a
entre
daily
5 gramos
consumption
de
of
sal
5 grams
o
of
2
salt
gramos de sodio.
or 2 grams of
Sin
sodium.
embargo, las cifras que
However,
tenemos actualmente
the numbers that we currently have
duplican y hasta triplican
double or triple
llegando a 15
up to
gramos.
15 grams
Y también
of salt per
era
day.
evidente que a través de diferentes
And
estudios
through different
la
studies,
disminución de la
they've
sal
seen that the decrease of salt
significativamente
consumption had a
en la
significant
disminución
impact
y el riesgo
in
de
decreasing
presentar
the
enfermedades
risk of
cardiovasculares, accidentes
presenting
cerebrovasculares
cardiovascular
y
diseases, stroke,
cardiopatías
and
coronarias.
coronary disease.
Otro elemento clave de
Another
nuestro
key element
presentación
in his
es que
presentation
la mayor
was
presencia de
that
ingreso o el mayor
the
ingreso
higher
de sal es cuando se
intake of
consumen
salt is when
alimentos
we consume
procesados y ultraprocesados,
processed or
que
ultra
llega
processed
a un
products,
ingreso de sal en un
which
80% y esto es
increase that
consumido
salt intake by
preferentemente por la
80%.
población. Nos presentó el acrónimo
He also
que nos
showed
permite
us
conocer
the
cómo
acronym SHAKE,
poder
that
enfrentar
we can see
el
how
tema de el control
with
de hipertensión a
the
través de la
hypertension
disminución de la
control
sal.
by
Nos
decreasing
hizo un
salt consumption,
planteamiento que hay que mejorar
indicated
la
that we need to
eficacia
improve
del consumo de
surveillance
sal,
on salt
hay una
consumption.
necesidad de la
There's a need
movilización del
to
sector
harness the
para
industry to
actuar
promote
en beneficio de la
reformulation
población y
for
hacer de
foods,
conocimiento de qué
to
importante es
inform
la
the
reducción de
population
la
of the
sal.
importance of salt
También
reduction.
nos habló de una
You also
adopción de
talk about the
normas
adoption of
permanentemente el
standards
etiquetado
and talk
frontal de
about
alimentos como
labeling
un
of
instrumento
food as an
de visibilización del riesgo
instrument
del alimento que se consume,
to
pero a la vez también
creating awareness of the
un,
risk of the consumption of that
un documento,
nutrient,
perdón, una
and also
evidencia, una herramienta que nos
a
permite
tool that allows
que
us
los productores de alimentos tengan más
or allow
control,
or
ya que los etiquetas con
indicates that
marcas
industry
pueden ser
need to be
rechazadas
more careful
u observadas por la
because
población.
the
Luego
population is going to be
México,
aware
como un país donde se ha logrado
high content
reducir
of
la
these
población es uno de
nutrients.
los
Gave the
alimentos que son
example of
consumidos
Chile
masivamente
of
por ellos, por
massive
la población
consumption
chilena,
of
y
foods,
es el pan.
and it's
Pero
bread.
lejos de generar un
But
conflicto con
far
las
from
panaderías, se
generating a
logró
conflict with
a
the
un
bakery
consenso a
industry, they
través
are
de una comunicación
achieve a
de las
consensus
partes.
through
El
discussion
punto
between the
final
parts.
dentro de sus
And the final
recomendaciones es
recommendation he
mencionar
made is
que
related
hay que informar a nuestra
to we need
población,
to
a nuestros
inform the
escolares
school-age
y a la población en
children
general
and
del
population in
consumo
general
de
the
alimentos saludables.
consumption of healthy foods.
Finalmente, nos dio a nuestro
Finally,
conocimiento algunas
he
metas que se han
gave
establecido
us some
para ir progresando en la
goals
reducción de la sal
in
de
terms of
cara a los
salt
años
reduction for
2020-2025 y que las
2022 and
mismas han ido ya
2025.
2022-2025, los mismos que ya han ido
And
avanzando y
some
cumpliendo
countries have
su
made progress in achieving these
meta
goals
para disminuir el ingreso
in
de la sal
decreasing salt
en diferentes
intake
alimentos que son de consumo
in different foods. Dear Dr. Leo, thank you very much for your presentation. We invite all those present here and our speakers to start our videos so we can go for the Q&A that have been sent through our chat. Send your questions.
Para nuestros expositores. Vamos a hacer las preguntas.
We're going to start the questions in the order of the presentations. We will start with Dr. Martinez. Among the strategies established by the Pan American Health Organization and the World Health Organization for hypertension control, what do you consider the ones that are of high value for the Ministries of Health in order to improve the information at that level of the Ministry of Health? Go ahead, Dr. Martinez. Thank you very much for the question. The answer is that we have to study and review the implementation of the initiative from PAHO in the region of the Americas, precisely to reduce the prevalence of hypertension and to increase hypertension control at population level. This is an initiative called HEART for the Americas that has accumulated a large body of significant evidence for the implementation of an action group at the local level, or the first level of care, that are aimed precisely to achieve greater access to diagnosis of hypertension, greater access to treatment, and that the treatment is effective, as Dr. Drago mentioned and emphasized during his presentation. Not only important that people are treated, have a prescription of medication, they need to be followed up, and those receive the adequate drugs to control hypertension, and that people are followed. The patients are followed on a systematic. This leads to a number of operational transformations in terms of primary care that in order to achieve these goals. There are other elements that have not been mentioned here that have to do with the use of devices for systematic measurement of blood pressure, and that these devices are validated. These devices that we find in the market or in the country are validated, and they may bring significant consequences in measurements of the blood pressure and impact both sides. We may be diagnosing a person as hypertension when it's not, or vice versa. So the answer is to invite you to visit the page of PAHO related with the HEART as initiative, where today we have 32 countries in this region of the Americas that are participating in this systematic work, strong work with these countries. We invite you to join us in this initiative. Thank you. Thank you, Dr. Martinez. A question for Dr. Drago. What has been the evolution of the incidence of hypertension and most common comorbidities? For example, diabetes mellitus, chronic renal failure, and other vascular diseases, stroke, and renal conditions. Well, we definitely see that the lack of adequate diagnosis and control of blood pressure in our country has an impact on the statistics. We see how in 2017, MI as a cause of death had the fourth or fifth place. In 2021 is the second leading cause and only faced by the death due to the COVID pandemic. We hope that when the ministry reports the mortality of last year with the reduction of the COVID mortality due to the vaccines, in fact, the MI mortality will be the leading cause of death in Peru, as we see in most countries. Some were surprised that we didn't have that same situation in Peru. So hypertension is the most important risk factor for ischemic coronary disease. In our society, recently in our last Congress, in the month of April, we reported the first Peruvian registry of heart failure nationwide. I invite you to visit our web to have the most important outcomes, and you're going to see how in patients with cardiac failure that are admitted to the ER, 60% of them have a history of hypertension. That's one of the consequences of hypertension, ischemic disease that may end up in death or failure, or stroke is another of the prevalent problems. It is known, following the epidemiological studies, by decreasing blood pressure has a higher impact in stroke as opposed to what was previously shown. But the published by those famous trialists in hypertension, they always had a higher impact in stroke. And with treatment of cholesterol, the opposite, they had a better impact in coronary disease and less for stroke. But hypertension certainly has an impact on both the conditions. So we need to make an adequate control. And following what has been mentioned today, to talk about prevention of cardiovascular disease, we can talk about primordial prevention, which is being demonstrated with this heart strategy. Change the lifestyle of the population, the food habits, and emulate a healthy lifestyle with physical activity, weight control. But these are long-term strategies in order to convince and make a change in the population that's going to take several years or decades. We, the cardiologists, see the patient when it has hypertension already, and we usually see complicated hypertension patients. That's why in our statistics, we show that 85% of our patients were taking more than one antihypertensive drug. If we go to primary care levels where you can detect hypertension, we need to incentivize the treatment of pressure. It's not to provide a drug, but also do an effective control, establish a goal, and that goal has to be sustained in time. If there's variability in pressure, that's another factor going to harm the cardiovascular system. So the longer the control of hypertension, the patient will do better. So the best way to achieve this is precisely by evaluating blood pressure control and treatment that can make them reach the goal in a permanent way. So that is a way that you can achieve this. And there you're going to have an impact in a major reduction in this cardiac failure to 50%. Coronary disease at least 25%, as reported by studies made with antihypertensive drugs. So we need to go that direction with an adequate diagnosis, early detection, and adequate treatment of blood pressure by physicians for the patients that have hypertension in large number. Thank you, Dr. Drago, Dr. Nedervin. And the multisectorial approach, what strategy would you recommend other ministries in addition to health ministry, such as labor, production, economy, education, and agriculture? to improve the approach of hypertension that is increasing in our region.
Bueno, pienso que
Well, I
muchos
think
sectores
that
pueden
many
jugar
sectors
un
can
rol.
play a role.
Cuando hablamos de
Now, when
reformulación
we
de los
talk about
alimentos,
reformulation of
todo el
food,
sector de
all the
procesamiento
sectors
agroindustrial
that
tiene que
has
jugar un
agro-industrial
rol,
processing
es
has to
decir,
play a role.
industria, obviamente.
The industry,
También el
obviously,
tema de las
in,
escuelas,
and also
al
in the schools
establecer normas y
by
estándares
establishing
para la
standards
alimentación
for
disponible en escuelas,
the
no
foods
solo
available in the
en la
schools,
alimentación escolar,
not only in the
sino también
school
en los kioscos,
nutrition
necesita
program, but in
el
the
involucramiento
expenditure
del
machines, and
Ministerio de
we need
Educación también
involvement of
al
the Ministry of Education.
promover la alimentación
And by promoting
saludable
healthy nutrition
a través de la educación nutricional,
through
el papel del
nutritional
comercio
education,
es
the role of
muy
education,
importante.
education is really
Eh,
important.
en cuanto a
In terms
industria, también
of
tenemos que
industry, we
hablar
also
de
have
tener lugares de trabajo
having
saludables.
healthy
También
workplace
podemos promover
where
la
we can
alimentación
promote
saludable y la
healthy
actividad física, que
nutrition and
también
physical
es
activity,
importante porque
which is
también
also
influye
important
en
because
la
it has an
hipertensión. Además,
influences
con
hypertension.
agricultura podemos
In
trabajar
addition,
con
with
pequeños
agriculture, we can work
productores
with small growers
para fomentar también
to
la producción y
promote
consumo de
the consumption
las frutas y
of
verduras
fruits
porque ellos
and
tienen
vegetables
potasio y
because they
eso
have
tiene un
potassium,
efecto
and
positivo
that has a
sobre
positive
la presión arterial. Entonces
on
hay
blood
muchas
pressure.
formas
So there are many
que
ways
sectores aparte
that
de la
the
salud
sector,
pueden
in
contribuir.
addition to the health sector, can
Gracias, doctor Leo. Bueno, y una
contribute.
última pregunta para
Well, a final
para
question
cada uno de ustedes.
for each one of you.
¿Cuáles considera que son,
What do
doctor
you,
Ramón,
Dr.
cuáles
Ramon,
considera que son los
what
espacios
do you consider
estratégicos
that are the
para el
strategic
aterrizaje
spaces
oportuno?
for the adequate screening?
De nuevo, yo creo que el
Well,
espacio
I think that the
estratégico
strategic
es el
space
nivel de atención primaria.
is at the
Creo que
primary
hay que hacer un
care
esfuerzo
level. We need
importante
to make a significant
porque
effort
haya capacidad
so
de
there
detección
is
de
they
hipertensos,
can increase detection of
haya
hypertensives
capacidad
and have the
de
capacity
acceso a medicamentos,
of
a
access
diagnóstico y acceso
to
a medicamentos,
diagnosis and medications,
medicamentos efectivos,
to
medicamentos
effective
de primera
medicines,
línea,
first
que
line
hoy día
medicines.
en muchos países desafortunadamente estamos
Many countries,
utilizando
fortunately,
lo
are
que se
using
llama trago, medicamentos que no son efectivos.
medications that are not effective.
Creo que hay que fortalecer la atención
We
primaria,
need to
preparar los
strengthen the
equipos
primary
de la
care
salud
by
que trabajen
preparing the
precisamente en ese
teams
tipo
so they can
de
work precisely as a team
y que hagan o sea, que haya una labor de
and
seguimiento
to
importante
have
para
a
lograr la
significant follow-up
control de la
to achieve
hipertensión en nivel
the
local.
goals of controlling
Yo creo
hypertension.
que hay que fortalecer el resto de los niveles de
We
atención,
need to
la
strengthen
atención
the
terciaria también,
other levels, the
porque
secondary and
en
tertiary
ese
level,
nivel está un poco
that those
mejor
levels
preparado y
are
creo
better
que ahora lo
prepared.
que
And I
logramos
think what
hacer
we
es
need to
una
achieve in that case,
articulación de
the
referencia
coordination for
para
referrals
logrando
in
muertes en
order
caso de
to
eventos, pero
prevent death in
cuando
case of
hablamos de la
event.
hipertensión,
But when we
creo
talk
que
about
podemos
hypertension, I believe
trabajar, creo
that
que
we
es un
can,
rol fundamental. El
the
espacio
most
estratégico
important or
fundamental
strategic
es en la
space to
atención
work
primaria.
is
Salud.
primary care.
Bien, muchas gracias.
Thank you.
Y agradecemos la presencia de todos
We
ustedes.
thank
Una última pregunta, diría,
your
por favor, muy
presence.
rápida,
And
al
it is a
doctor
final
Drago,
question for Dr. Drago,
relacionado con
and is related
la inercia terapéutica.
to therapeutic
¿Podría
inertia.
darnos ejemplos concretos
Could
de
you
su
give us some
experiencia en el diagnóstico y tratamiento de
examples
hipertensión arterial?
of this situation in the
La inercia
diagnosis and
terapéutica
treatment?
es
The
nada más
therapeutic
que
inertia is the
cambio de conducta
lack
ante un
of
resultado que
change
puede ser
of
adverso.
behavior
Y la
facing an
inercia
adverse outcome.
terapéutica se puede dividir en varias.
This can be
La inercia
divided
por
in
parte del
several.
médico
The inertia by the
que ante
physician
una presión que
that
no está
by
controlada no la adopta
uncontrolled pressure doesn't adapt a behavior to correct and improve that blood pressure. We need to insist that on colleagues, in particular our society that has a mission to educate cardiologists and make sure that they are updated. We always have insisted in that we reach adequate levels of blood pressure and we promote the use of combinations. There's also inertia by the patient side. Patient may feel well, and sometimes they don't see a effect, or they may decide not to take medication, and that can lead to events. But there's also inertia by the health authority and regulators and those who finance health. Have a fragmented health system where the state intervenes, but also the private institutions participate. We have a number of situations where many times we have to justify treatment. And that we should need to change the way they think so the person can access to the best therapeutic schedule, the one that he or she needs, regardless of the cost, because human life has no price, cost. So we need to favor human health above everything that needs to be done. So there are a number of situations, and here we need to promote on the regulatory agencies to approve the use of medications for adequate treatment. A suggestion with regards of how to improve from primordial prevention. There's a study made in Peru in the region of Tumbes, a very interesting work where the common salt use was replaced with a salt that was half sodium and half potassium. So we can do an intervention on processed foods, but on the daily consumption of people who prepare their own food, offer them a salt that is not just sodium, but also potassium, be acceptable palate. This, and he demonstrates this in this work by reducing the content of sodium and increasing the potassium content that is acceptable for the population. He decreased the emergence of hypertension. So an adequate way is to use combined salts in a formulation that can be accepted, decrease hypertension. Whereas the best way to detect hypertension is occupational control. As soon as the person starts working, everyone should be evaluated with measurement of blood pressure, which is very simple, but can be significant for their health. And from there, refer to the specialist that corresponds. With that, we can reduce the problems we have and all the pressure that go against the population by increasing the number of cases of hypertension. Thank you, Dr. Drago. And finally, Dr. Leo Netherbean. Could you quickly tell us about hypertension, sanitary measures such as salt control? Thank you. I mentioned there is a very close, almost linear correlation between salt consumption and hypertension. The reduction of salt benefits everyone, not only those who have hypertension, but those who have normal pressure. Sometimes it's a misunderstanding that reducing salt is only for hypertensive patients, but there are benefits for the entire population. In fact, there are populations in the Amazon region that have never consumed or seen salt, and they obtain sodium or what is naturally present in food, and their blood pressure is perfect. So
mejor y
el-
además en general tener un estilo de vida
having
saludable,
healthy lifestyles and
evitar
reducing salt consumption
bajar
and
hasta
physical
niveles de
activity,
obesidad y comer
controlling
alimentos
weight,
naturales
and
y
consuming
reducir el
natural
consumo
elements and reducing
de
the
los
consumption
alimentos
of
procesados y
processed and
ultraprocesados a partir de
ultra-processed
la
foods
reformulación.
in addition to the reformulation.
Muy amable.
Very kind.
Damos un profundo agradecimiento a
We
nuestros
thank
expositores.
our
Hemos recibido
speakers.
múltiples
We have
felicitaciones
received
a través de las redes
many
sociales. Para dar el cierre a
congratulations
nuestro webinar,
to
invito a
our
la doctora María del Carmen Calle Dávila,
group,
secretaria
and I
ejecutiva,
invite Dr.
para las palabras
Calle for their final
finales.
words.
Doctora María
Go
del
ahead, Dr. Calle.
Muchísimas gracias, Lucho.
Thank you,
Bueno, mis
Lucho.
primeras palabras son de
First words,
agradecimiento al
thank
doctor
Dr.
Martínez,
Martinez,
al doctor Drago, al doctor
Drago,
Naverdin,
and Dr.
por
Navardin for this,
estas exposiciones tan
for their
claras y contundentes.
presentations that have been so clear.
La hipertensión sigue siendo un problema de salud
Hypertension
pública.
is still a public health,
Definitivamente
continues to be a
el
public health
diagnóstico
problem,
precoz y
and the early
tratamiento
diagnosis and
adecuado
adequate treatment
es indispensable para
is
poder contrarrestarlo.
indispensable
Sin embargo,
for
yo quería hacer algunos
its treatment.
pequeños comentarios.
But I would like to make a few
No,
comments.
no olvidemos que también
We should
niñas,
not forget
niños y
that
adolescentes
girls,
pueden
boys,
sufrir
and
de
adolescents
hipertensión.
may have hypertension,
Y realmente la indicación
and
es
the
comenzar
indication
a
is to
medir la
start
presión desde muy
measuring
pequeños para
blood
eso hay
pressure
normas
since they're small. That's why we have
especiales para
special
niñitos
cuffs
pequeños
for small
y
children,
la recomendación es medir a
and
partir
the
de los 3
recommendation is
años
to start at
y
the age of
bueno,
3
con mucha más
and
cuidado en aquellos niños
be
que
very careful
tienen
with those children
obesidad,
who have
sobrepeso,
obesity,
que tienen
overweight,
hábitos
or
familiares,
family history,
porque en la niñez una de las
because
primeras
during childhood,
complicaciones de la
one of the
hipertensión es el
leading
cáncer
causes
de
of
la renal.
hypertension is renal disease.
Entonces siempre hay que
So
recordar que
we always
también
have to
en
remember
niños y
that in
adolescentes
boys, girls, and
tenemos
adolescents,
presión alta.
we have
El
hypertension.
segundo tema es
The second comment
el enfoque de la
is
hipertensión
the
definitivamente
approach of
es multinivel,
hypertension
¿no?
is at different
Digamos,
levels. So
los pacientes con los estilos de vida
the
saludables,
patients with
con
healthy
buenos médicos,
lifestyles,
haciendo los
physicians
diagnósticos
with
precisos,
adequate
las
diagnosis,
autoridades
the
facilitando, ¿no?
authorities by
El poder hacer el diagnóstico y dar el
facilitating
tratamiento
diagnosis
oportuno, ¿no?
and
Y
treatment
definitivamente
on
a
a
la
timely
población en
basis,
general
and to the
también
population in
sobre
general
todo que
by
vigilando que se cumpla con esto.
monitoring that there's
En el Perú hay
compliance
una
with this.
guía, no solo
In
en el Perú,
Peru,
en los 6 países hay
in the
guías
6 Andean
guías
countries, we have
para la toma
guidelines
de la presión
for
y cuáles son los
blood pressure
medicamentos,
measurement
todo
and the
digamos, todo eso
medications.
está escrito,
Everything
está
is
en
written,
normatividad.
it's
Otra cosa es que
standardized.
se hace
Now,
realidad.
it's a different story if they follow
Considero
it.
que el primer nivel de
Consider
atención
that the
es el
first level of
nivel de
care
atención donde se debe
is the level of
diagnosticar
care
la
where
hipertensión.
hypertension needs to be
Cuando
diagnosed.
ya el tema es
When
complicado, ya debe
the
pasar a
condition is
especialistas,
complicated,
pero
it
la
should go to the
hipertensión
specialist. By
debe
hypertension
diagnosticarse en
must
el
be
primer nivel.
diagnosed in the first level.
Y como lo ha dicho el doctor Drago,
And as
digamos,
Dr. Drago
enfermedad
mentioned,
silente, ¿no? Y cuando
silent
nosotros
disease,
preguntamos
when we
a la población en general,
ask the population in
¿qué
general
síntomas tiene la
what
presión?
symptoms the
Dolor de
pressure has,
cabeza,
headache,
mareos, ya,
dizziness.
cuando uno tiene dolor de cabeza y
When you
mareos es
have a
porque ya
headache and
ha pasado
dizziness,
un tiempo
it's
de
because
que ya está
there's
con
been
presión.
quite a time with
Así que
hypertension.
siempre recordar que esta es una
So we
enfermedad
have to
silente
remember
y
that
que
this is a silent
definitivamente
disease
la
and
toma de la presión es
the blood
obligatoria.
pressure
Y vuelvo a repetir,
measurement
no
is
nos
mandatory.
olvidemos de niñas, niños y
Once
adolescentes.
again, don't forget boys, girls, and
Por
adolescents.
otro lado,
On the other hand,
sí funciona todo lo que, bueno, lo que han comentado de
what
este
you've mentioned
reemplazo
about this
del cloruro de
replacement of
sodio,
sodium chloride
ha sido una experiencia
that has been
exitosa.
a successful
Existen otras
experience.
experiencias exitosas
There are many other
en torno a
successful
esto.
experiences in
Sin
this regard.
embargo, casi siempre estas son
However,
pilotos y
this has all
no,
remaining pilot studies.
no van a escala, ¿no? Eso es lo que nos
They don't
falta
scale
en
up.
Perú. Hay
That's
muchos
what we
pilotos,
need
pero
in
no se
Peru.
van a
There's a
escala.
lot of pilot
Pero
studies,
creo
but we don't scale it up.
el etiquetado es fundamental.
Labeling
Trabajar para
instrumental
disminuir
in working
la
to
cantidad de sales
increase the amount of salt
productos que más se utilizan
in the
también.
products that are most
Entonces,
frequently
creo que hay
consumed.
muchas
So
cosas que todavía
there are many things that
se
we
deben hacer.
must be done.
Ahora, definitivamente el disminuir sobrepeso en
And by
obesidad
decreasing
tiene que ver
obesity and
con
overweight
una dieta
has to
saludable
do with a healthy
y
diet
la mayor
and
actividad física.
higher physical activity.
Por los estudios sabemos que no,
We know
no se
from the
realiza
studies
mucha actividad.
that there's not
Y en
much
se acaba de
activity,
publicar no
and the
solamente
survey
el tema
has
de la
published not
hipertensión
only
por los estudios en que estamos en hipertensión,
we
sino
know
también sabemos
what we
que el
are
sobrepeso y la
where we
obesidad
stand in
son
hypertension, but we also know
problemas
that
muy serios
obesity and
de
overweight
salud pública
are a serious
y tienen
public health
relación
problem
con la hipertensión.
and are related to hypertension.
Solamente quiero agradecer
I would
por el tiempo que
like
nos
to
han
thank
brindado
you for your
los
time,
excelentes profesionales,
our excellent
agradecer a
professionals.
Lucho Bengolea,
Thank Lucho
todo
Bengolea
el equipo del
and all the
organismo
ORAS,
andino de salud que
the
hace
Andean
posible
Health
que
Organization
semana
team that makes possible that
semana
week after
contemos
week
con los webinars
we have
que
the
nos brindan
webinars
un
that
espacio
offer us
para
a
reiterar
space
mensajes
for
importantes.
continuous
Si
interlearning.
aprendemos nosotros,
Learn,
aprenden los profesionales
the
de salud
professionals
y
learn,
también
and also
aprenden la población
the
en general.
population large.
No quiero terminar
I
sin
would like to
invitarlos al
invite
siguiente
you
webinar
to
que
the
será el
next
día
webinar
25 a las
on the
5 de la
25th
tarde,
at 5
cuyo
p.m.
tema será
We're
seguridad
talking about
vial
road
en América
safety in
Latina,
Latin America,
retos y
challenges and
oportunidades para alcanzar
opportunities to
las
reach
metas
global
globales.
goals.
Muchísimas gracias.
Thank you
Buenas
very
tardes,
much.
buenas
Good
noches,
afternoon.
buenos días.
Good evening.
Gracias.
Thank you.